Thank you. Well, welcome to the Western Regional Training Center and Health Services Research Seminar, both in Saskatoon and Regina. And today we have a quite unusual presentation because it involves a large cast of characters. It includes, of course, myself, Greg Marchildon. I'm the site director for the WRTC here at the University of Regina, as well as a professor in the Johnson-Shoyama Graduate School of Public Policy. It also involves Don Philippon, who's Professor Emeritus from the University of Alberta, and a former decision maker and Deputy Minister of Health in Alberta and Assistant Deputy Minister of Health in Saskatchewan, as well as Amber Fletcher, who's a research associate involved with us in this project from the very beginning, and a special guest who I will let Don introduce later. And Don's going to kick off this presentation.
Thanks, Greg, and welcome everybody who's come to this session today. We're going to be talking about a research project on health leadership. It's a national project of which there is a node we're going to talk about here. And I got to do this, right? Once again. So the first thing I want to do is kind of give the context for this project. And I got to talk here and look there, I'm told, so I got to just keep what I'm doing here. So first of all, the Canadian Health Leadership Network is a fairly new network in Canada. In fact, I was one of the founding co-chairs of that. It exists today. You can find its website. It was formed in 2006. There's over 30 organizations that are partners, both national organizations and provincial organizations. And early on in the process of developing that organization, of course, the goal of which is to facilitate the building of capacity to develop leadership in the country, we developed sort of three lines of sort of activity. One is developing tools for leadership development, facilitating dialogue, and identifying research needs that exist. And one of the first things we realized is that there is really very little leadership research done on health leadership in Canada. In fact, I would say that leadership has been almost a throwaway word in Canada. Every document you read about health system change, and we need leadership. Whether you're talking about Aboriginal health, whether you're talking about information systems, whether you're talking about primary care. But what do we really mean by this leadership we're talking about? So we identified the need for really starting to focus on the meaning of leadership in the Canadian health system context. Also early on involved the development with other people, and I'll introduce Graham Dixon in a few moments, on the leadership capabilities framework. And many of you have heard about LEADS in a caring environment, which is really getting widespread adoption across Canada as a framework for leadership development. So that's the CHLNet part of the origin. So we were very interested in having leadership undertaken with respect to leadership in healthcare. The Centre for Health Leadership and Research at Royal Roads University, which Dr. Graham Dixon was the director at that time, was also very interested in that, and they had done a lot of the founding work on LEADS. In fact, Dr. Graham Dixon is the person who actually developed the LEADS framework. So we actually partnered with them, and in 2009, submitted an application to CIHR under what's called the FISI competition, Partnerships for Health System Improvement. There were 19 co-applicants, and by its very nature, a FISI application has to include both researchers and decision makers. So it's across Canada, and we got our grant approved in 2010, and as far as we understand, it's the first ever CIHR-funded grant on leadership in the health system in Canada. The design, of course, is an overall secretariat that is supported out of Royal Roads University. It's a 4-year project, and basically that's the funding we got is both from CIHR and funding in kind, and also some from the Michael Smith Foundation in BC. There are 6 nodes to this project. So each node is looking at leadership through a somewhat different lens. So the BC node is looking at the implementation of what they call our IPCC model, which is the Integrated Primary Care Model for British Columbia. Ontario is looking at family health teams. Atlantic is looking at both physician and citizen engagement. And at the national level, there's a node on quality, access, and appropriateness. And in the prairies, which is the one we're going to talk about today, we ended up focusing on the Shared Service Initiative in Saskatchewan. So the prairies, of course, being Manitoba, Saskatchewan, Alberta, the first task was to identify how would we identify a project. We wrote to all the CEOs of the health systems in the 3 provinces. We wrote to the deputies, and came to the conclusion that the project we wanted had to be one that would fit in that 3-year time frame of the project, and would have to be a project that went from sort of design to implementation in that period of time. And out of that, the Shared Service Initiative emerged as the priority for the prairies. Now, at this point, I'm going to turn the podium over to Dr. Graham Dixon, who tells us a little bit about the LEADS framework, because it does fit into the research that we're going to be talking about in a few moments. Okay?
Thanks, Don. And I look forward to discussing this with everybody because I've been spending a lot of time on it over the last few years. As Don's given you the background, I'll just take a few minutes to explain what the content of the framework is about. And essentially, you could view this really as a knowledge mobilization product, in the sense that it is to capture the essence of what we know in the literature about good health leadership, experiences in focus groups and interviews with people across the country about what they perceive good leadership in the health sector to look like, and also an analysis of leadership competency frameworks internationally and nationally. And that created 3 pots of data that we distilled down and said, essentially, if you're to be effective as a leader in creating reform in a health system, and we did bring a systems view to it, that you needed to be able to do 5 things very well. First thing you needed to be able to do was to lead yourself, which means understand how you show up in the presence of other people, your emotional intelligence, understanding your goals, your values, your assumptions, and recognize that leadership is going to demand the exercise of character at times and self-development at times in order to respond to the challenges of change. The second element of the framework is, great, you're really good at leading yourself, but now maybe it's important to actually engage other people in the reform agenda. And this is really the relationship building aspect of LEADS at an interpersonal level. Communication skills, team building skills, developmental skills of others, keep making sure your own organization is a healthy place to be. Third element of the framework is achieve results, and it really is the element that speaks to much of the management of change, responsibilities, vision setting, measurement, making sure that the vision and measurement are aligned with values and beliefs and with evidence, because the health sector, more than any other sector, probably needs to be guided by the actual empirical evidence that certain things work for the benefit of patients. And it's about getting results. Leaders have to get results or people will not invest in their endeavor. Fourthly, another relationship development component is developing coalitions. Much of what service that is delivered to patients in the system is a collaboration between professions, collaboration between organizations, home and community care, a hospital, public health. We need to be very skilled at making those collaborations work. And finally, systems transformation, which essentially is you need to be a very skilled leader at understanding the dynamics of change in a systems context, both small and large. And those 5 domains of leadership ultimately are the buckets of knowledge and skills that a leader needs to be effective in the health sector. Note that the framework is called Leads in a Caring Environment. One of the things that we heard from people is that we needed to respect the identity of the health system as we interpreted the leadership, research, and language. And the identity is we care for people. It's the business we're in, that's what we're about, and this framework speaks to operationalizing that caring ethos. I won't speak to many of the others here because I'm very conscious of time. But it has been endorsed. This framework has been endorsed by 33 national agencies, provincial agencies. It's represented in 10 provinces across the country. And it's also been picked up in Australia as a reflection of what good leadership looks like in an Australian context. So with that, I'll turn it back over to Don. Thank you.
Thanks, Ben. So now we'll focus more on getting down to the actual research project itself. And as I said, it's part of a national study. So there actually are 3 common research questions that all nodes are trying to address. So what is the current state of health leadership capacity in Canada? What's working, not working in terms of stimulating and supporting health system transformation? And what contextual factors influence effective leadership action? All 6 nodes are addressing this. Second question, what are the gaps between current practice and the evidentiary base in the literature and the expectations for leadership? Outlines an emerging health leadership capacity, capability, or competency frameworks. And how might a set of national standards for leadership be structured? So here's where the leads piece does come into our work. And third, how can knowledge of effective leadership be translated and mobilized into approaches? There's a big knowledge translation aspect to this study, and we regard this event today as a part of that process to make all of you aware of what's going on. So programs, tools, techniques to develop a culture of effective leadership in Canada and enhance the development of quality of health leaders. Common research questions. So then as I said, we selected what was that time called the Shared Service Initiative. And I see Mike Shaw in the back of the room, who was very instrumental in getting that going in the province. Welcome to have him here. And we worked with Mike in the early days to try and define the research around this. So what is the Shared Service Initiative? For those of you who might not know about it, basically it's looking at all of the what we call the back office functions of the health regions and how can they basically pull that together and do that on a shared basis provincially. So to obtain economies of scale and scope without having centralization. So a very big contrast to what happened in Alberta where they centralized everything. Here, let's leave the health regions in place, but look, the function we can do together, let's try and do them effectively together. So this decentralized approach requires leadership in what remains a highly distributed system. And I said why it was selected before in terms of it's province-wide in scope. It fit with our time period, go from design to implementation within the 3-year grant we had, and it's a current high priority across Canada. So with that, when you look at the challenges that come about in trying to bring about the shared services objectives, it's recognized that a culture change is required. The mantra in Saskatchewan, of course, is think and act as one, even though we are maybe 12 health regions or 13 health authorities. Requires leaders to break down institutional and historical barriers. And without effective leadership, old behaviors just will continue. So how do we change that culture? And to need to recalibrate leadership as the project proceeds. So part of the purpose of this project is as Greg will tell you, it is participatory action research, working with the decision makers, people doing it, to study how we're doing as we go along so the whole project can sort of be refocused as it moves forward from design to implementation. And I think that gives us opportunities to correct and to respond, to adjust the initiative, and it really requires an extensive discussion between the researchers and the decision makers to reflect and to see how this whole initiative is proceeding. And again, as I said, this is one of the reasons for events like this today, and there will be others over the next year where we try and diffuse and talk about what we're finding in this research project. I think with that, Greg, I turn it back to you to talk more specifically about the project.
Okay, there are many lenses through which you can view leadership, and there's been a lot of research in general leadership outside the health system over time. And probably the one that we most often think of is through the lens of the heroic individual. It's why comic books exist. It's why we go to action movies. And despite the fact that we all know deep down that this can't be the be-all and end-all of leadership, it may not even be a part of leadership, we tend to think of leadership in that sense. So it's important that we understand very explicitly that lens that we bring to it. Another is to look at the kinds of traits or behaviors associated with leadership, try to enumerate them, and then in the case of behaviors, we try to replicate those behaviors and sometimes traits to get the kinds of leadership outcomes that we want. Another approach, and this has only been probably in the last half century that we have focused in, is looking at context and realizing that leadership is very situational. It very much depends on the kind of context that you're operating in, and And what we call effective leadership in one context may fail in another context. So we need to understand the structure that we're operating within, the nature of the relationships. Another area that has undergone considerable study in the last few decades is the difference between transformational versus transactional leadership. And that's pretty important in health systems thinking, because this is an area where you may think that you're involved in more incremental change, but to achieve the objectives that you want to achieve, you might actually have to do something that's more transformational. If you get that wrong, you're not going to achieve the outcomes. And vice versa may be true. You may be portraying to the world that what you're engaged in is something very transformational when it can be something quite transactional. And you will need very different kinds of leadership under both scenarios. You will need much more profound leadership in that transformational environment. And then the final thing is, and this has been research that's been in the last 20, 25 years, is the idea of leaders as servants. I guess it's always existed, but I mean real empirical research in this idea that, in fact, leaders are, in a sense, serving a constituency, serving a membership, that they are, in fact, sacrificing in the process of doing so. And this is not at all about the heroic individual and that individual's ego. This is, in fact, about subsuming ego. This is about putting aside your own desires and basically working on behalf of your constituency in a very profound and self-sacrificing way. For those of you that are parents in the audience, you know exactly what I'm talking about. So this is just a little picture of what we mean by a heroic or charismatic leadership, but it's also implicit in many of our hierarchical organizations. Whether you're talking about the military or you're talking about a government bureaucracy, it's highly hierarchical, in part because of accountability and reporting. And even though leadership may not be exercised in this way, we think of it this way quite often, or it's presumed to be this way through the organization chart. In fact, and this is becoming increasingly evident, and not just in the healthcare environment, but in many other environments where you actually have this combination of servant, network, and distributed leadership. But when you're looking at healthcare in particular, whether it's this environment or it's in other countries, it's one of the most highly distributed environments imaginable. And you're often working with organizations that have autonomy, with independent contractors, whether they be physicians or other professionals that have autonomy, and you're working with networks. They can be informal, they can be formal, but your ability to act as a leader with respect to networks, independent individuals and organizations is absolutely critical to achieving success in this area. And that's a very different kind of leadership than in a single organization, like a private corporation or a health management organization in the United States or a single government department. And we need to recognize the different characteristics and features associated with that kind of environment which predominates in health systems. There was one piece that research that was done a few years ago that focused on Quebec. It's been fairly well distributed, called The Messy World of Healthcare. It involved 3 case studies in Quebec, and it examined the details of doing leadership, and under very serious constraints, because it was at a time of cost cutting. There was less money, and of course, because of the layoffs involved, as well as the premium that this placed on the time of the senior leaders in the organization, these became critically important considerations. So it was a study of leadership under real time and under real constraints. And there were 4 features that emerged out of this research. And it was described in the following way, that you could see leadership in part as a dynamic in which what you do now sows the seeds of either future growth or opposition. And so that you had to understand the medium and long-term results of any short-term actions. And in fact, you could have very surprising results. And that is the fourth one, leadership is a dialectic. So what might be effective in the short run could actually be very counterproductive in the medium and the long term. So you had to, in a sense, be able to visualize what the medium and long-term impacts, not just the short-term impacts of a given leadership action. Another way was looking at leadership was leadership as a collective, and of course the need to build coalitions with co-leaders in surrounding networks. And what they exposed in this research was the fact that there were literally dozens of these networks, both formal and informal, and effective leaders had the ability to forge links and to have relationships that were constructive and productive through these networks. The next aspect of leadership was leadership is situated, and that is the importance of behavior here, the importance of personal behaviors in all action, that in fact leaders were constantly being watched by others, their actions, and they were being evaluated. And that if a leader underestimated the impact of that, they would likely misinterpret what was going on later. That their actions, in effect, had very large echoes throughout the organization. And it was what one person said to me long ago, which was, if you really want to understand someone, don't listen to what they say, watch what they do. So actions do speak louder than words in that respect. Now, there are some broader health system challenges that this research we hope can be applied to. And I want to emphasize, and we'll talk about this later, we're only at the first cycle of this research. We have a minimum of another cycle to go through, and we're not going to be able to take this research and say what are its implications for the broader health system till we're done. But these are the areas that personally I think we're going to be able to have something to say about. The first is that we know that structure and strategy is emphasized considerably in the course of health reforms. But what we often don't consider is the leadership aspect of it. It's sort of the missing ingredient. And I'll give you one example of that. There was a chain reaction when regionalization was first introduced in Saskatchewan and Quebec. It then triggered through a number of other provinces. And basically, people have been working on the strategy and structure of regionalization for decades before that, have been thinking about it, planning for it, encouraging it to happen. But the missing ingredient was leadership. We didn't know what we were really doing, going from a system in which people were managing individual facilities and they were silos to a situation in which we were building a system, in which we were trying to manage this in terms of the full continuum of healthcare, or at least a broad continuum of health services. And the kind of people that were used to running hospitals and long-term care homes weren't necessarily equipped to, in a sense, manage and lead in this new three-dimensional environment. And we didn't anticipate it, we didn't train up for it, and we didn't bring in people from outside the country to help us with that, because we really missed that ingredient of leadership. We didn't calculate that into the reform. Now, there's obviously a high degree of cynicism towards structural change, because we often resort to structural change pretty quickly in health reform before we figure out everything else. And what we see is a situation where the movie changes, but the actors remain the same, and they keep doing the same thing even though it's a different movie. And in a place like Saskatchewan, that happens with a vengeance. I don't know how many rooms I walk into, it's the same cast of characters, but we all have different roles and we're all in a different movie. But we keep doing the same things and we keep saying the same things. Well, that is the issue. And if you don't change and people's behavior and actions do not change, and their perspectives do not change, you're not going to get a different result, even though the structure changes. And so that's really one of the issues that we have to focus on when we're dealing with leadership. The next thing is that systems thinking must be combined with a greater self-awareness of the roles within the system, and there's often not a very good understanding of the other roles in the system. And the fact that you've worked in the health system for 30 years in a particular role doesn't mean that you understand the health system. It means you understand your profession, your role, and your part of the system. And in fact, what may have happened is that you assume you know the system, so you haven't taken the time to actually study what the rest of the system looks like. You don't know what you don't know. And that can be very dangerous in a situation where you're trying to move to some reforms. The next thing is that, and this is a dynamic, and it's just, we all just have to look in the mirror to see where the problem lies, and that is we will generally blame others for the problems in the system. If they could only manage properly, if they could only do things right, it's always somebody else. And yesterday we were at a workshop on physician engagement and leadership, and it's the discussion in the operating room lounge among surgeons. Those administrators don't know anything. If they could only listen to us, the system could get fixed. And I'm sure the administrators, when they get together, they have their conversation. And I'm sure it's equally finger-pointing towards the physicians and others as well. But we all do that, and we all tend to do that. And the real point here is that when that is going on, you can be almost assured that there are very few conversations among these various groups, so that they're not getting to know each other's respective worlds. And finally, the extent to which leadership is exercised, we have to recognize this, it's exercised under serious time and financial constraints. There's still the opportunity to make very important choices, but there's also some very serious time constraints and financial constraints. As Dawn said, this is participatory action research. We've tried to capture this in a bit of a diagram that we adapted from a very different context. But on the one side, what you see is both leadership, research, and practice on the one end. And you have to, in a sense, learn those worlds and understand those worlds. And in the case of the leadership theory, there's an extant literature that I've already talked about. But when it comes to practice, this is the advantage of participatory action research, because the researchers have to work with the decision makers. And the decision makers are going to inform them of leadership practice in that particular domain, and they need to learn as much as they can with their decision-making partners about that, or they're going to get it wrong. On the other side of it, of course, there is the broader areas of the literature in terms of, in our case, qualitative research and figuring out the right type of qualitative research to apply. And in some cases, and you're going to hear from Amber shortly about how to modify existing techniques to fit the kind of research and achieve the research objectives that you've set out. And then finally, there's the research subject or context. This is about health systems research. It's the reasons Dawn and I are involved in this research, and we bring that literature to the table as well as our own knowledge. Now, on participatory action research, we involved decision makers from the very start. That included, and Mike Shaw was heavily involved in terms of the initiative itself, but we also involved Maura Davies, who is the CEO of the Saskatoon Health Region. She was actually involved with Dawn in the original design of the project and with Graham. And we use a very iterative process in which we actually worked with some of these key decision makers at the front and then we work with the larger group of decision makers as we go into the actual process, and then we feed back that to the decision makers and give their responses back to that research. So you're going to hear about how iterative it is in a minute. It involves knowledge transfer mobilization by definition. We don't have to set up somebody. Dawn is officially known as our knowledge transfer and mobilization director in our project, and I'm officially known as the research director. Those labels are meaningless in some senses because we do everything. And we expect, in some senses, that the decision makers are going to become part of the research. So these labels over time should become almost meaningless. Okay, now I'm going to turn it over to Amber to talk about our approach. And I'll just quickly say that to introduce this, that there were two phases in our first cycle of research. In phase one, we conducted 39 interviews. We divided up these leaders into 3 leadership groups. They're separated and assessed by decision-making authority and power. We used open-ended interview technique, but we also used a Likert rating scale, and we did the analysis using in vivo 9. And at the second phase, we used the Delphi survey, and Amber's going to talk about a little bit about this, but we had to modify the Delphi instrument, and we had to use it to, in fact, push our interviewees in terms of the questions and their interpretation in the first round, as well as rationale. So, Amber, get you to come up here and talk about our results.
So I will be presenting some of the aggregated results of our research. This is, of course, not all of the research results. These are the ones specifically pertaining to the LEADS framework. And at given junctures, I'm going to try to sort of tie that together with the methods that we use, so you can get a sense of how the methods led to the results. So starting off, as Greg mentioned, we did use a dual strategy in the first phase of this research cycle. The dual strategy was kind of condensed within the interviews. So first we had open-ended questions in our interviews, and that's what we started with. We then went into Likert scale questions, which I'll talk a little bit more about in a few minutes. But first, just to focus in on what we found from those open-ended questions, which were really quite general and really helped us to get kind of an organic, straight from the participants kind of idea of what the important leadership characteristics to them were without having to prompt them or to probe further. So you've got, of course, the LEADS framework, which you've seen already here. And there were 3 particular items within that framework that the participants in the research emphasized as the most important to them. The first was engaging others. And within that particular LEADS item, there's a subcategory about using effective communication in order to create that engagement. That was considered particularly important for the participants, who emphasized regular communication, meetings, check-ins, other forms of communication in order to really keep the initiative moving forward. The second LEADS item that was highly emphasized by the participants was developing coalitions, and in particular, the subcategory of using or building, using pre-existing or building new partnerships and networks in order to keep the initiative moving. Participants really emphasized the importance of using working groups that had existed prior to the initiative in order to further the initiative. They also emphasized building new partnerships and networks, for example, between themselves and their counterparts in other regions. So that was considered to be a very important strategy as it pertains to leadership as well. Finally, the third LEADS item that emerged from the interviews, and again, this was all discovered through our coding process, it was achieving results. It was considered very important, and in particular, 2 of the sub-items, aligning decisions with vision, values, and evidence. Of course, evidence was stressed by participants as a very important component of their leadership and their decision-making throughout the process of the initiative. And secondly, assessing and evaluating outcomes, again, using that evidence. So evidence was considered very important. And you can see here how these particular sub-items relate to the main items on the LEADS framework. So it was very much an effective test of the leadership framework and what was most important out of that framework in this leadership initiative. In addition to that, there were some other highly emphasized leadership characteristics. These ones were not specifically contained within the LEADS framework as it stands, but of course they are part of the overall, the buckets of LEADS, as was the metaphor that Graham used earlier. These were identified again through the coding of the interviews, so they emerged in a very kind of organic way from the participants themselves. These clusters of characteristics are, as you can see, integrity, credibility, and trustworthiness, long-term vision, commitment and perseverance, and humility and flexibility. These clusters were generally following the way the participants themselves spoke about the characteristics. They often grouped them in this way, so we've tried to replicate that and stay faithful to that as much as possible. As you can see here, these characteristics were pulled out of the interview data through the coding process, which I'm happy to answer some questions about if you're interested in what we did for that coding process. But we then placed them into the Delphi survey, which was the second phase of this research cycle, and allowed the participants to confirm that these were indeed important, to elaborate on them if they wished, and also to rank them so that we could get a better understanding of how important they are in relation to each other. So as you can see, integrity, credibility, and trustworthiness were considered the most important by all of the participants. You've got also some average overall rankings on the side, which as you can see does indicate that there were some participants in some groups that did not necessarily rank this particular cluster to be the most important. There were some that clearly ranked it in other ways in order to get that 1.78 and not a pure 1. Also, long-term vision, considered second most important uniformly by all groups on average. Again, there were some who clearly did not consider it to be second and did rank it lower. Commitment and perseverance, interestingly, was considered third most important by the higher level groups, but was actually considered to be the least important by the frontline leaders. So that's an interesting difference there, especially when you consider that humility and flexibility shows a reversal, where the frontline leaders considered that to be more important than commitment and perseverance. So there's some interesting interpretations that can come of this data, and some it really justifies the use of this follow-up Delphi survey in order to understand how exactly these characteristics are playing out at different levels amongst the participants. So that covers off the characteristics that we managed to extract from the interview data. As I mentioned, within the interviews, participants were also asked to rank specific characteristics of leadership styles and behaviors taken right from the LEADS framework on a Likert scale of 0 to 10, with 10 being that they had emphasized that as the most important. We did these Likert scale observations in two ways. The first was that participants were asked to rank each leadership style or behavior, or rate it rather, on a Likert scale, according to how much importance they personally had placed on that particular leadership style or behavior in the initiative. The second time they went through it, they were asked to assess how much importance other leaders in the initiative had placed on that particular leadership style or behavior. So there was a self-assessment portion, and there was also an assessment of others portion, which allowed us to get some very interesting results. There were 5 items where we found a statistically significant or near statistically significant difference between the groups and their average ratings on that Likert scale. In particular, in the self-assessment, Group 1 considered developing a vision and setting direction to be a very important leadership characteristic for them, whereas that was seen by Group 3 as not as a very important focus in their leadership. The other 4 characteristics were all focused on the assessment of others. So we only had the one statistically significant element in the self-assessment. And in all 4 of these characteristics, it's interesting that Group 2 tended to report that other leaders were putting more emphasis on the characteristics than the other was noticed by representatives of the other groups. So we have here, just to go through these characteristics, we have creating teams that use cooperation and collaboration to achieve results, creating connections, trust, and shared meaning with others, developing methods to gather and use evidence to improve action, and negotiating through conflict and understanding the socio-political environment. So because we were very interested in why the groups saw the differential emphasis in the way that they did, we wanted to follow up with that. We wanted participants to be able to interpret in their own way what they thought was behind these differences. So we asked them in the Delphi survey that followed, the second phase of the cycle. Participants mostly attributed these differences between the groups to the different roles of the actors involved. So there wasn't as much insight into those differences as we had hoped, but it was a very interesting exercise overall, not only to get a sense of how the different groups viewed things, but also just to get some confirmation of what we had pulled from the interview data. So with that, I will turn it over to Greg to talk about more findings.
Well, thank you. And I want to say that Amber is very close to completing her PhD dissertation, but I, as one of her two supervisors, I noted that she was a very skilled and I would say innovative qualitative researcher, which is the reason that I asked her to join us in this project, because I knew it would require the modification of an existing technique, and it would involve qualitative research at a pretty sophisticated level. I'm delighted to say that she did join us and that she's going to stay with us for the remaining part of the project, even if she completes her dissertation on time. So that's great. She also keeps Dawn and I honest in the sense that she really does understand what the data is saying. And then when Dawn and I try to interpret it, she tells us if we're going too far. And what I'm about to do is get right into that interpretation. And the first area I'm going to talk about is vision. And in that sense, I want to talk about the fact that this is an interpretation. It's based upon data, and you're going to see some of that data in these boxes in each of the 4 slides. But first there was the problem identification that came clearly out of the data that was analyzed by Amber through NVivo. And the problem here was that group 3 leaders felt that group 1 to 2 leaders had not really communicated a well-articulated vision for shared services. So given that that was the issue, we then went back to them through the Delphi survey instrument, and we set out a number of potential ways that that could be addressed. These are not complete solutions, but they're intended to be options to address the problem. And we asked them to rank them in their various groups. So from frontline leaders to the people that were part of the Shared Services Central Secretariat to the really high-level leaders in the system in Group 1, from the Minister and the Deputy Minister of Health to the CEOs of all the health regions. We just asked them. And surprisingly enough, everybody came to exactly the same conclusion here in terms of the average tendency, that Groups 1, 2, and 3 agreed that there needed to be more communication between the central office, which eventually became known as 3S Health, and the CEOs of the health regions in particular. That was going to be the, and that speaks to the nature of this system, which is in fact a very loose system in which we have independent health regions, and in a sense the central group is considered to be now particular closer to the Ministry of Health than it is to the regions. And so there was the idea, at least by this time, that there needed to be more communication then between the central group and the CEOs of the health region, and in turn, and we know this from some of the other data, more communications from the CEOs of the health regions through the various personnel within the health regions. And that was more important than communication between the ministry and the central group for shared services or anything else. Now, engagement. Engagement means more than sort of engagement at sort of the vision level and the planning level, but in this case, we also were dealing with the very beginning of implementation, the very, very early stages. So think of engagement throughout all of that. And the problem here is that while everyone agreed on the importance of regular engagement through meetings, check-ins, and continual communication, Group 1 really depended on Group 2 to accomplish this, and the Group 2 people said, we were not able to devote the time necessary to engage the frontline leaders, Group 3. And the reason for that was, at the beginning stages of this project, these were people that were basically working out there in regular jobs in the system, and they were seconded to do this work, and they had to do it off the corner of the desk. I think everybody recognized that this was not a permanent solution. It was a way to get the project going. But the downside of it was that these folks had very limited time in which they could. Remember I talked about time and budget constraints? Well, this is a serious time constraint. And they themselves, when they reflected on it, they felt that they did not have the necessary time to devote to this. I've just been told to stay closer to the mic. I'm the one person that should know that, and I'm the one person that strayed away. I apologize. But the point here is that then what do you do about this problem? So through the Delphi instrument, we suggested some possibilities, and again, even though there was some difference, there was some agreement among Groups 2 and Group 3 that the CEOs of the health region needed to engage the employees as well as stakeholders that were not part of the region but people directly affected by this kind of changes in the supply chain and the back office functions, that they needed to communicate more with these individuals. The next one is a particularly difficult one, but we managed to, and we spent some time in interpretation here, but the problem was, and it was often called government, but we had to get beyond that. We had to figure out, well, what do you mean by government here? Because government could include the health regions. It might not include the regions. It might just be the cabinet. It might be the political party in power. What do you mean? And in exploring that, what it appeared to me and to Don is that it meant both cabinet and the ministry. The ministry was viewed as part of, whether it was the minister or it was the deputy minister and the officials in the Ministry of Health. That was the government as interpreted by everybody. And the view was that while the government had the appetite for change and to initiate all of this, that once some opposition to it begins to occur at the local level and gets transferred through the MLAs and everybody else back into government and back to the ministers, including the Minister of Health, then there might not be the stomach for this change. And that there was a fear that the government would in fact reverse the change. And okay, we understood the problem. That's a very common problem in policy reforms. There's always that fear on major reform that the government might reverse itself. And then there are the cynics that just assume that the government will change its mind in a couple of years and all they need to do is keep their heads low and just ignore the reform and it will go away by itself, right? So there are all those kinds of attitudes out there. But we said, well, what are the things that could be done about this? And so we suggested at least 4. We always ask people to put their own. If they didn't agree with any of the 4, they had other ideas. But what we found was, in fact, that again, all 3 groups agreed that there needed to be a clarification, if you like, and a better communication of the overall vision. Now you might say, well, what does that mean? Well, it means that the vision and the objectives were not fully understood. And even if they're understood on one day, it needs to be repeated later on so everybody can remember what the real objective here is. What is the ultimate destination? But keep in mind that this is at the stage of vision and planning. We have another cycle to go in which we're actually looking at what's happening on the ground during the implementation. And by the time we're done, at least about two of the streams will have completed implementation. So we're going to find out if this holds true during those later stages of implementation. The fourth challenge was personal leadership. And here it can be summarized as basically a lack of sufficient awareness of an individual's own leadership challenges. In other words, quit blaming other people, quit looking around and saying, the ministry's wrong, or the regions are all wrong about this, but what about your own responsibility? Your own individual ability to shape outcomes. And here there was a clear sort of lack of self-awareness by many individuals responding to the interview and but then when we asked in the subsequent survey, what can be done about this? A number of things were suggested. And again, for groups 2 and 3, the people that were sort of directly involved in the planning and the frontline implementation part of it, what they said was, we need to understand more about change management. Everything from training programs, education, talking to each other, but we need to understand the process of change management and our involvement in that. From the perspective of the Group 1 leaders, it was about better communication. That came out on top. It's the key factor in terms of changing this. So you can see that there's a difference among the groups as to the perceived remedy for the leadership challenge. I'm going to end on this slide and open up to questions, and I'm sure that this presentation has probably raised more questions than answers. But our research design for our next cycle is to really focus in on the implementation. And that's already started. We started in October, and we're going to go to September of next year. That's our cycle. And we're going to pursue a number of issues in much greater detail. So it's going to be a narrower focus, but it's hopefully going to be much deeper. We're going to really try to find out how best to reduce the leadership gap in terms of tools, learning opportunities, etc. We're going to try to figure out whether the Shared Services Initiative has made a major difference in overcoming what we call natural fragmentation. There's fragmentation in two senses. One is in terms of this is a decentralized health system, so there's going to be a certain natural fragmentation as a consequence of that. But there's also a fragmentation in terms of individuals, and we were talking about this earlier today, that we see everything from the perspective of our own profession or our own role in a particular organization. And there's always going to be a tendency to see problems as coming from somebody else or from somewhere else. And it's very difficult to overcome that fragmentation. It's like working against gravity. And leaders have to recognize that they're working against gravity and figure out what kinds of tools, what kind of devices, what kind of dialogue do they need to overcome that kind of natural gravitational pull. The next thing that we're going to try to plumb the depths of is causality, and that is whether in fact there is a major change in leadership styles and behaviors during implementation. Is this project triggering those kinds of changes, or is it basically a different movie, but everybody's behaving the same way even though they're supposed to have a different role? And then finally, and this is going to be hard for us, we're going to have to be very truthful with ourselves, we're going to test whether this participatory action research And the reflection that it, in a sense, induces on those that are participating actually is at any independent impact. That opportunity to sit down and talk about this. And the truth is, we don't know, and it could very well be having no impact or will have no impact. Just a few contextual factors. There has been a change of leadership and individuals due to the creation of this central agency called 3S Health. It is not part of the Ministry of Health. It's a Treasury Board Crown Corporation, but it's not part of the regions either. And there's, because of this change, we're going to have to see what impact that has had. We know that there's decision maker fatigue with us and our questions, so we have to be very focused in what we do, and we have to promise not to use much time, but we also have to, in a sense, deliver something back during the course of this. And we hope that we can make the conversation as interesting as possible for individuals to be able to donate that kind of time, both in the first part in our individual interviews and later in our focus groups. We're going to do some pilot or trial interviews this time. We learned from last time that we're going to do 6 of them to make sure that our questions are right so that we can refine them and get them right for the whole set of interviews. And we have to recognize that a bit of shift has occurred, so we're going to have to recognize what's happened here in terms of the Lean Initiative and the potential twinning of this project with the Lean initiatives in terms of the Saskatchewan health system. So on that note, I invite you to ask us questions. We will direct the question to the appropriate person, so please proceed. And on this note, I have to now be moderator, so it's my responsibility to shift to Saskatoon and ask if they would like to ask the first question.
Hi, can you hear me in Regina?
Yes?
Okay, so my question is, I wonder where you've put the boards, the authorities in your research design. Perhaps in the first go-around, shared services was just normal activity, but with your change in the contextual factors, it no longer is.
Yes. And that's a very good point, actually, because in terms of the role of the boards, in Group 1 we had 3 board members, and they involved chairs of the boards, 3 different boards, because we recognize the governance arrangement here, and the fact is direct transmission between the minister and the various board chairs. This was, in fact, and maybe we can get Mike Shaw to speak to this, never really seen as business as usual. This was seen as more of a health transformational effort from the beginning, and in that you need to recognize the governance arrangement and that you can't just go to the CEOs, but you have to involve the boards in some fundamental capacity. Question here? Regina? I thought we had a question. Yes.
Well, I'm not sure as usual, but I'll stick with the one that interested me the most. I noticed towards the beginning, Greg, you were talking about the organizational structure was very different than a single firm or government department. And I would suggest, and I'd just like your thoughts on this, perhaps not as different as you think. I think you've always been at a fairly high level in the government department. I think the roles you were describing are the sort of classic middle manager, which every organization seems to be losing. And every transformation initiative that I've seen recently, says a key impediment to change is middle managers. Well, it strikes me they're usually the ones trying to make these connections and make the change initiative match the rest of the...
Okay, those are two separate questions. On group 2, and I'm going to invite others to respond as well, but group 2 is that middle management group, if you like, middle to a little more senior. What we did not see so much a change in that group as we saw a shift in terms of organization and the way in which it was organized, so that these folks no longer have to manage this off the corner of their desk. A group was hired to basically work on this full time. Your more profound question concerns organization. And I would argue, yes, this is very different than a typical government department. Even if you have branches and units within that department that act as semi-autonomous, there's still a chain of command. There's still clear accountabilities, and it's very hierarchical. In this, you're dealing with the Ministry of Health, regional health authorities, cancer agency, and a number of healthcare organizations that are not, in a sense, part of the public system, but they contract with the public system. They may be private, not-for-profit, or private for-profit. This is a system as opposed to a single organization. But on that note, I'll ask Don maybe to comment.
I got the question totally right, but like some of the comments that Greg made at the beginning about with more general comments, not so much about the project, but about organizational structures. But when you look at this project, it is very different. I mean, because, and I don't know if we adequately explained to you the 3 groups. The 3 groups we really interviewed have really 3 different perspectives. The first group were really the senior group, including right up to the minister, the deputy, the CEOs. The middle group, as Greg has just said, was basically vice presidents and sort of the upper sort of middle management. And group 3 were really people that really were directors of purchasing or IT or whatever that are going to be directly affected by that. So we're getting perspectives from the 3 levels. But the organization of the project really drew a picket at the group 2 level, people from across Saskatchewan, from across organizations, into a setting where they jointly had to plan this initiative. So they were pulled out of their individual organizations, brought to the central team, each having responsibility particularly for maybe a certain stream, but still thinking of the overall province-wide. So the attempt here was a very different approach than trying to run it from within an existing department or an existing health authority. It was cutting across the whole, very much of a systems approach.
Question from the boardroom in Regina or from Winnipeg?
I have a question. This is Lisa in Winnipeg. Hi, it's specifically for Amber. I wonder if you can speak to, as a student participant, Amber, about some of the key things that you learned in terms of being involved with this research team and the participatory research process. Both the things that worked really well and the things that may not have worked so well.
I think it's a good question. I think there are sort of 2 sides to it. The first, of course, and maybe a bit more straightforward, was that it was definitely a learning experience for me in terms of subject matter. I hadn't really worked extensively on health systems work before. So in terms of the subject matter, it was a very interesting learning experience in that respect. On the other side, it was interesting for me to be able to work very actively and you know, in many ways, to have more involvement in the design and in the research methodologies and that sort of thing than a student usually does on a research project. So it was very interesting to be able to construct and to experiment with methods, to be able to find the most effective ways of dealing with the ethical issues involved, to deal with the different methodologies that were needed to get at the answers that we wanted to reach. So I think between the 2 sides, it was definitely an interesting learning experience and one that has very much helped me in my own doctoral research as well.
Amber, maybe you could comment on the Delphi method and the way in which it was adapted, what it was used for, how it was adapted, as well as if you could describe in just a little bit more detail the challenge involved in the ethics process because of the power differentials and the pre and post interview consent form that was developed. I mean, you were quite inventive in terms of that, and would like you to maybe comment on it.
Sure. Well, I guess to pick up on what I was saying before in answer to your question, this was a significantly complex research project in terms of the methods and the ethical approaches that were needed. So I guess just to start with the method, as you mentioned, Greg, we used the Delphi approach, and I'm not sure how familiar people in the audience might be with the Delphi. But just to give a very basic definition, the Delphi method or Delphi approach it's defined as a structured communication tool. So it basically involves rounds of returning to the participants with the results from the previous round in order to get confirmation of those results, to allow the participants to elaborate on the results from the previous round. Typically involves 2 to 3 rounds. But it can be as many as the researchers decide to be necessary. Conventionally, the purpose of the Delphi method as it was designed was to facilitate consensus building. So it actually originated during the Cold War to determine munitions targets. So we've used it in a significantly different way, as you can see, but it was formerly used to gain consensus. So participants would receive the results of the previous round, whether that be from a survey or from open-ended interviews, and they would then get a chance to change their answers in light of the group response. So it was trying to get the answers to come together and to not have such disparity in the answers. That wasn't really our primary interest. Our primary interest was more to document how people's views changed over time, how their involvement with the initiative changed over time. So because of the multiple rounds and the time lapses involved between the rounds, when you're processing the data, coding the data, converting it into the next round's questions, it allowed significant events to happen in the initiative so then we could come back during the next round and ask, well, what's changed? What new things have developed, and has your leadership changed? Has your view of leadership changed since we previously talked to you? So as Greg mentioned, we've now completed the first cycle, which involved the 2 phases, the interviews and the Delphi survey. And then we'll have 2 more cycles consisting of focus groups, interviews. We're still working on that methodology at the moment. The main modification then for us was not only the purpose of the Delphi, but also that we used it in a much more open-ended way. We weren't really interested in statistics as much as is typical in a Delphi. We were more interested in giving the participants the opportunity to interpret the answers, the group answers that they saw, and to give us some insight as to what these findings might mean. And that also helped us to make it a more participatory experience as well. So that's how we modified and adapted the method, and we are working on getting those results out there right now, as you know. In terms of ethics, which was the second problem that we came up against, the typical ethics approach in qualitative research, which is basically to have informed consent and assigned consent form, was not going to cut it in this project because we have leaders representing a multitude of levels of authority within the system. We needed to keep people's confidentiality more within their control. So what we came up with after a literature review was to do something called a post-interview confidentiality form, which is different than your usual pre-interview consent form where people agree that their name won't be used, and that's usually it. Instead, we decided to also allow the participants to select out any information that they might not want to be put into a publication or into a report or disseminated further. For example, if they were to tell a story that might give their identity away and then think later, I shouldn't have said that, they now had a chance to select that information out. We did have 4 participants who chose more than a basic level of confidentiality, which was changing their name. One actually wanted to read through her transcript and to select out some stories, and that was fine, and we did it that way. So we felt that this was a way that we could really enhance the participants' control over what we did with their information, and I think it worked out quite well.
Were you able to identify leadership skills they all wanted? You were able to identify leadership skills that they all wanted to adopt and the organizational impediments to adopting those skill sets, but can you elaborate more on the personal characteristics section in regards to their own inability to be self-reflective and their own personal impediments to becoming better leaders. It seems like none of them could do that. They only blamed everything on the organization itself, really.
Yep. Well, I'm going to let Amber answer most of that question, but I don't want to give the impression, in fact, that they lacked all self-awareness and that they did nothing but blame other folks. That there was a lot else going on, and while obviously some did blame other organizations, I would say that, in fact, there was a fair amount of self-reflection in that group too. The realization that the lack of time had prevented them from doing certain things that they felt were really important, and they reflected very hard on that. But Amber, I'm going to let you get into the issue of the characteristics.
Yeah, I mean, definitely to add to what Greg said, there were several participants who were on their own time actively engaging in leadership development at a personal level. So for example, listening to leadership courses on an MP3 in their car, what have you, taking courses, those types of things. So definitely there was some personal attention to leadership development, but in other cases, as Greg mentioned, there were cases of finger pointing, cases of blaming external forces and that type of thing. So there was a mix, definitely. Are you also asking about what types of personal leadership characteristics came out? So you'd like to know more about the lead's characteristics? Oh, okay. That's something that, if I may, Greg, that's definitely something that we would like to address in the next cycle. It just came out in this first cycle, so we need another cycle in order to get to those.
Go ahead, Don.
So probably as the least of the researchers among the bunch, and with Amber on my side here to correct me if I'm wrong, because this is, as Greg has said, it's really good in qualitative research. It's so easy to bring your own frame of reference to this. And you hear somebody say that, but is that really the overall? The sense I did get out of that is that, and I think that's borne up by some of the other leadership literature, is that people don't really think often in terms of their own contribution to that leadership. They don't often reflect on what they can do differently themselves. That seemed to come out of this, I think, you can correct me. And there were some examples, as Amber just said, where people did talk about it. But when we asked the question about what this stimulate further learning on your part, things you wanted to do, there wasn't a lot of uptake on that. So I don't know if I go so far as to say it was all sort of finger pointing, but there didn't seem to be the same degree of acknowledgement that you as an individual in a leadership role can do things to shape and influence the outcome here. And have you really thought enough about your own leadership style? That didn't seem to come through really strongly. But am I still on safe ground? Okay. Greg, do you want to?
Yeah, frontline leaders were very quick, though, and I read the transcript because, the aggregate results don't give you a complete feel for this, so you have to go back through the transcripts, and you sometimes say, well, why are we doing in vivo then? We're just going back through the transcripts. But I'll tell you, what hit me was the frontline leaders were the ones that were saying, I need more courses, more knowledge, more access to executive education and change management and health system leadership. They were very explicit about that. And they're actively looking for ways to learn about it. And you might say, well, they're looking for tools. But I think it's more than that. And here's my interpretation. I think it has something to do with self-awareness. I think they want a greater self-awareness, and they know they don't use that terminology. And we shouldn't get bound up with if they don't use that phrase, then that they don't know what they're after. I think they do know intuitively, and so that came across in a powerful way. I think that we have to explore this issue in much greater depth in order to get a very good read on that. And I think that probably what happened is we just simply scratched the surface, and now we have to figure out a way to get beyond that. My co-researchers tell me that we don't need a behavioral psychologist to help us, that we can figure our way out of this. I'm hoping that we can, but this is for me, appears to be one of the most difficult areas to try to get at.
just wondering if you could comment a bit. Leadership's moving, you said, towards a more networked and distributed leadership model. And with our current focus on lean, it's also focusing on leaders at all levels of the organization. And I believe that within your study, you looked at the management level of leadership. I was wondering, and you also talked about kind of the physicians and kind of the role definition between physicians and administrators. I was wondering if you could comment on how that would bleed through to other levels of the organization on other or on reform initiatives in general.
Well, not absolutely everyone in Group 3 would be considered a manager, but I must admit that most are, that there are people that work for them, and then that would be the traditional sense of a manager. But I don't know, and I'll invite anybody in the group to speak to this. I don't know how it applies to non-managerial individuals at this point. We won't probably know that until cycle 3, and we'll have to be careful about the inferences that we draw. But what that speaks to is probably something that we haven't addressed, and that is probably to make sure that we have, in a sense, one non-managerial or two non-managerial people in Group 3, if not at the individual interview level, to make sure in the focus group we include that group, and then we can maybe get some answers. The difficulty is that by having this Group 3, you will have a power differential between those who are managers and those who are not. And so we're going to have to be careful on how this is constructed, because you're not going to have people speaking very openly in a forum like a focus group if their bosses are sitting in that room. And that's what we've tried to avoid. And we need to avoid that, because even though you put them in a room, what you're going to get is not going to be very reliable. Ron, do you have anything to add?
I don't know, I'm looking to Graham. I'm going to try and get him in this discussion, because I think that the concept of leadership that Leeds brings to it, it's not tied to a position. It's tied to whatever individual and whatever level of job you have in the organization, how you can exercise leadership and what you do. And you're right that in this particular study, we did pick people in the 3 groups that all had sort of some form of managerial responsibility. But I think the success of the overall initiative will go well beyond that. It'll involve all people who have individual roles, and we haven't. And I think, Greg, I think your questions are very good one for us to reflect on who we have to include in the next cycle to really think about how leadership is really exercised. But Graham is by the way, is the principal investigator for the overall national study. He's also the person who's developed the Leeds framework, and he may want to comment on this in some way.
I don't want to add a lot, other than the fact that I want to emphasize Don's point that our perspective on leadership is that leadership is a function of what you do, not the position you hold. You can hold a position, but you can be incredibly ineffective as a leader because of how you behave in that position. Because leadership essentially is granted by the follower to the leader. The follower decides whether they're going to follow someone else's lead or they're not, unless they're forced through some sanction to follow. Otherwise, if sanctions aren't on the table, then they're going to follow behavior. And they'll withhold that followership if they believe the leadership is being, positional authority is being inappropriately used. Now, you're absolutely right that we haven't operationalized that construct effectively in our current study. This is more a study of the practice of managerial leadership. And we do need to be more open and clear about that in our explanation of it. But it does bring up a really interesting point, and that is that if you get a book called The End of Leadership by, sorry, I've forgotten the woman's name, just left me. Her point is that people in formal positions of leadership have had their power eroded over time through experiences like the internet, the ability of an individual person in a democratic society to stand up and exercise the behaviors that give them the right to lead. It's an interesting thesis.
Question at the back, but Saskatoon. Is there any further questions from Saskatoon? We should really. Or the boardroom in Regina?
No questions in Saskatoon.
Then we have a question here.
Question.
Oh, there's one in the boardroom? Okay.
Yeah.
Hi guys, great presentation. Was it ever considered the newness or that this has never been done before? So it's new territory for this type of project. Do you think that had any impact on the results? And are the other nodes that are being looked at across the country, is it looking at the same context in terms of territory that has never been, I guess, tackled before? Is that clear?
Yeah, well, the focus on leadership within the Canadian context, at least is, funded in a major way. As Graham said, it's the first time, but there's been other leadership research in other countries, and Graham can talk about that, but also in terms of maybe what Mike Shaw could say. I mean, why did the provincial government and Shared Services Initiative want this research done? Probably because they didn't have anything at their disposal that they could rely upon, and therefore wanted some real-time research while this was going on. But I'm guessing, Mike and Graham, you can comment on this if you want.
I'll just simply make the offer that there is a ton of research that is being done in the UK and Australia around leadership, and if anyone wants to know more about it in health systems, anybody wants to know more about it, just send an email to this group and forward it to me, and I'll pass on some salient information. There has been very little research done in Canada on the construct of leadership. And remember, Don introduced it as a term that is a throwaway term. A lot of people just see it as something. They're not quite sure what it is, and they're not sure how it's exercised. And we wanted to see if we could bring some degree of explication through this study.
I guess just maybe come back to the question, and I don't know if I've got it quite right, but if you're talking about our particular project, I mean, the issue of shared services is not a new concept. I mean, I've been in the health system for 30-some years, and we've tried this many, many times, and quite frankly, usually doesn't get anywhere. The approach in Saskatchewan that we took was very different in terms of getting buy-in from the whole system, getting people from across the province engaged in the design of it. And I think that was one of the interests of having this research project, to say we've got a very innovative approach here and how we're going to tackle this thing this time, even though we've tried it before and didn't get anywhere. So I think it's a way to look at an innovative approach to bring about this system change. Remember, the overall research project we're working within is health leadership and health system change. How do you use leadership to drive change? So this was a new way of doing it. I think that's what sort of put the spotlight on why we should study this particular innovation at this point in time and see what we can learn from it. And hopefully, if we learn things from it, then we can apply that to other health system change areas as well in the future.
I think this will have to be the final question. A couple of people here have to get to the airport, so thanks.
You may have already answered my question, but I guess 3S Health had a predecessor organization who did provide some of the same types of services. And so I guess my question is, when you're looking at change management, did most of the people you interviewed consider this to be a transformational change or a transactional change? And would that skew your results in any way?
Those are two very different questions, and I can't answer the second question because I just don't know. I mean, our starting position in the selection was that this fell more within the transformational category. It wasn't simply a matter of doing a few back office functions, but it was intended to have some pretty important impacts on the health system as a whole. And the idea of, and I'll put it in the phraseology used by the people that had the original vision for this, was act as one, have this health system act as one. We've been engaged in that reform for 40 years in this country. and no one has really truly achieved that ultimate goal. And therefore, we, as many people would say, we do not have a so-called health system in this province or in any other province. We have a series of health systems that are loosely connected. But this was an attempt to draw some of that much in a much closer way, but without creating a single bureaucratic organization along the lines of Alberta Health Services. Now, the question you ask is, if I can be very specific, did the 39 interviewees say this was a transformational change? We did not ask that question in that way, but I would say that a majority viewed it as a major system change. Now, if I could put it on a scale and say on a scale of 0 to 10, how does it compare to another major transformational change? I could give you a precise answer. So I have to be rather imprecise, but perhaps in the next cycle we need to put forward a more precise question on that. Because it would be it would be important to know whether all of the people we're interviewing feel the same way about it as the people that had the original vision. All right. Well, thank you very much. We really appreciate everybody coming out. I know it's getting close to the holiday period, so and classes are just ending, so thank you very much.